You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Brad White, and we're glad you joined us. Before we begin, I'd like to thank our sponsor, Aultman Health System. Today, we are broadcasting from our administrative offices, and our guests are Dr. Sabrina Shalad, fellowship-trained breast surgeon, and Dr. David Angari, lead radiologist, both with Aultman Breast Care Center. Good morning and welcome to the show, doctors.
Good morning. Thanks for having us.
Thank you.
Breast cancer is the most frequently diagnosed cancer in our community and the nation. Aultman Breast Center is the first Stark County facility to earn the Center of Excellence designation for the American College of Radiology. We'd like to remind our listeners today our program is available on our podcast. You can download that from the App Store in your favorite podcast app. Just look for Health Matters with the Medicine Center Pharmacy, and please subscribe to our program. Okay. Good morning, Dr. Shalad. Tell us a little bit about yourself.
So hi, I'm a breast surgeon at Aultman Hospital. I've been here since 2010. I'm a native of Mentor, so on the east side of Cleveland is where I grew up. And then I came to Canton after I finished my training. So my general surgery and med school training is when I ended up in Canton with my family. So it's been a wonderful place to live and have family.
Wonderful. Can you explain what it means to be fellowship trained?
So what fellowship training is additional training on top of the first set of training after becoming a doctor. So I went to med school, and so that was 4 years. And then I did general surgery training, which is 5 years of training, anywhere from 5 to 7. But I did 5 years. And then after those 5 years, I dedicated another specific year focusing on breast cancer and breast patients. My course was a little bit more unusual because I came to Aultman in 2010, and I was doing general and trauma surgery at the time. And then I sort of focused in on breast surgery. So after I'd been in practice for a while, then I went up to the Cleveland Clinic, and I spent a year up there focusing on breast patients. And so then after that, then I came back down to Canton.
I think it's fascinating to hear your education story and things like that, because sometimes I don't think we understand how much time and dedication it takes to get through that gauntlet. I mean, that's pretty impressive. So well done.
Oh, thank you.
Okay. So at what age should you begin mammogram screenings?
So the average risk woman, so that's just the normal woman walking around, no risk factors, no family history. So we tell most women that they should start getting their screening mammograms at the age of 40. So once a year, get a screening mammogram, starting at 40. And we usually ask women to continue at least until 75, unless they have major medical problems. And so the when to stop question is a little bit trickier. We tell women that's a decision or a conversation between you and your doctor. When it looks like your health is not so good, and we're thinking there might be less than 10 years left, then maybe we should stop with the screening mammograms. But every year, screening mammogram.
Okay. Dr. Angari, welcome to the show. Please tell us a little bit about yourself and what you do as the lead radiologist.
Sure. So hi, everyone. I'm a Canton native, born and raised. I did all my medical training here at Aultman. I've been medical staff since 2019, so I've been here for about 5 years. And like Dr. Shalad, I have subspecialized training in breast imaging and the diagnostic aspect of breast cancer. So contrary to popular belief, I do not perform mammograms. I just interpret them. So most of my work is done behind the scenes. Usually the only time you may see me or any of my other radiologist colleagues is if you need a biopsy or some other imaging guided procedure performed during the diagnostic process of your journey. And as the lead radiologist, my responsibility is to maintain the quality standards for our department.
Okay. So how often should a mammogram be done?
So like Dr. Shalad said, we do recommend it to be performed yearly, but sometimes we may ask for them to be performed a little bit more frequently than that, particularly if there's something that we're following. So we may ask for patients to come back every 6 months to have those imaged. But for general screening, performed yearly.
Okay. So Dr. Shalad mentioned that for the average risk person, they should start at 40. who would qualify or who would you consider to get screened earlier than 40?
So for screening, there's generally two scenarios in which a patient should start screening earlier than the age of 40. And that's really if they're considered high risk and the patient has a first degree relative with cancer, so a parent or a sibling. Screening should begin 10 years before the age of onset of that first degree relative. And then the other would be if a patient's had a history of chest radiation between the ages of 10 to 30, they should begin screening 8 years after the treatment, but not before the age of 25. And generally, if we're doing screening before the age of 30, we're asking to do that with MRI. And then once they hit 30, we say to do mammogram plus or minus the MRI. And that's for screening. So, but another reason that someone might, get a mammogram before the age of 40 is if they have symptoms like a lump, pain, skin changes, nipple discharge, etc.
Okay. Dr. Shalad, do you have anything to add about high-risk screenings and what it means?
So high-risk screening, so for our patient population who needs high-risk screening, and so we look at those same family factors that Dr. Angari mentioned, but we also frequently do a risk assessment called a Tyrer-Cuzick score. And so what a Tyrer-Cuzick score looks at is we put all sorts of different factors into a risk calculator. So we're looking at age of when periods start, age of menopause, whether or not extra hormone therapy was taken, age of first childbirth. We also look at other factors like height and weight. And so all these things come together, as well as breast density, to give us what we call a Tyrer-Cuzick score. And it predicts sort of a lifetime risk of developing breast cancer. And if a woman has a lifetime risk of developing breast cancer over 20%, then sometimes we do what we call high-risk screening. So high-risk screening is where you have your same mammogram screening once a year, but then also you can have an MRI once a year as well. And so the two of those modalities together, we're watching women very closely. Every 6 months, they're getting some form of imaging to, again, watch their breast closely.
Okay, so the big question, I've been at home with my wife when she's been waiting to find out about a mammogram. What does it mean if a mammogram finds something?
Yeah, I think that's a really important question to ask because when it does find something, it's really scary, and naturally thoughts start running through your head. Oh my goodness, I have cancer, but really that's not what it means. Screening mammograms, they do a pretty good job of detecting abnormalities, but they don't always characterize those abnormalities well. And sometimes those abnormalities we see are actually just normal structures. So when we see something on a mammogram, we need to evaluate it further in a more targeted way with either additional mammographic imaging, which with targeted views, ultrasounds, or even MRI, so we can determine if it's actually something that we need to biopsy or not. And then I always like to put things into perspective with statistics to better understand and put the information. So for every 1,000 screening mammograms, approximately 100 patients, or 10% of them, will actually be called back for an abnormal finding. And if it's a first ever mammogram, that can even be higher, up to 20%. But of those 100 patients, approximately 10 to 20 of them will actually need a biopsy. And of those 10 to 20, only about 3 to 10 of them will actually be diagnosed with cancer. So, with a 3 to 10% of those abnormalities that are detected coming back with a cancer diagnosis, I think that gives a lot more comfort and reassurance to kind of alleviate some of those fears that people have when they get that abnormal callback request.
Okay. Did we effectively cover the Tyrer-Cuzick score?
I think so. I think she explained it pretty well.
Sorry.
Okay. She stole your question. All right. A question we've heard in the pharmacy: does getting a vaccine affect your mammogram results?
So vaccines can affect your mammogram results because they can cause swollen lymph nodes in your armpit, or your axilla that we call it, that you may or may not be able to feel. And that can show up on the corner of your mammogram image. So it typically affects the side that the vaccine was injected on. It would be unusual for it to cause changes in your breast, but it can if it causes the swelling. Now, any vaccine can do it, but really we saw this with the COVID vaccine. It was notorious for doing that. And so when the COVID vaccine actually first came out, we were seeing seeing it so much that we were actually telling patients, let's delay your screening mammograms for up to 6 weeks. But now, as more literature and more experiences come out with the vaccines, we've stopped doing that. But we do still ask people for that information, just so the radiologist can have a better understanding of their history and interpret their exam better.
Okay. All right. Well, it is time for our first commercial break. You're listening to Health Matters with the Medicine Center Pharmacy. Okay, welcome back to Health Matters with the Medicine Center Pharmacy. Are you ready for vaccine season? Stop in and schedule your flu or pneumonia vaccine, COVID, or shingles. You can also go online at medshoprx.com, and we'd be happy to schedule an appointment for you. Okay. I know we talked briefly in the first part of the program about when women should begin to get their mammogram. And you kind of alluded to knowing when to stop's a harder problem. Can you comment on maybe when a mammogram isn't needed anymore?
Yeah, so there are different organizations that all have different recommendations on that. But from my standpoint and the societies that I adhere to, which is the American College of Radiology and the NCCN, really there is no age limit for a mammogram. So there's really never a forced stopping point. But I think it requires a conversation with your doctor, like Dr. Shalat alluded to, because there are scenarios that I think are reasonable to stop performing mammograms, like a limited life expectancy, or if the patient knows that they wouldn't pursue anything if breast cancer is found. So I think it requires a conversation with your doctor.
Okay. I don't know if you guys experience problems like we here in the pharmacy with patients who don't regularly have a primary care physician and therefore don't regularly get an annual physical. But I'm kind of wondering if you have trouble with women getting their annual mammograms just because they delay it or don't think it's important, or maybe because they don't have any family history, they think it isn't necessary. What do you tell a patient or someone listening today that might hear that?
I guess I would tell women to definitely keep getting or to go get a mammogram, even if they don't have any family history. So about 1 in 8 women get breast cancer, and that's without any family history. And so it's a lot of women who it's just all the environmental things that our bodies are exposed to, as well as our own independent risk factors. And so again, those are, the I guess weight is one of the bigger ones. I mean, but it's all the other things that within our life that our bodies are exposed to, which increases risk to developing breast cancer. So without any family history, it's still 1 in 8 women. And actually the genetic components of developing breast cancer, it's only about 5 to 10% of all the women who have a breast cancer. It's because of a genetic reason. And so an overwhelming majority of our risk factors are environmental. And so even if there's no family history, still definitely please go get a mammogram once a year, starting at 40.
Okay. What do you say to a woman who may have concerns about the radiation exposure from a mammogram?
Yeah, so I usually try to put radiation into perspective for patients so that they can understand it, because it does sound scary. Um, First, I'd say the amount of radiation used for imaging purposes is regulated, and all that equipment must be periodically certified by a medical physicist to ensure that it has adequate quality, and it lives up to the dose regulations. Secondly, the amount of radiation for a typical mammogram is incredibly small. And so, for perspective, every day just walking around, we're exposed to background radiation, just from our natural surroundings, mostly from the ground, but also from the sun. And then over the course of the year, we'll be exposed to about 3 millisieverts. That's the unit that we measure it. A mammogram has an average effective dose of approximately 0.3 to 0.4 millisieverts. So just about 1/10 of what you would normally get just walking around, outside over the course of a year. And some of our other medical imaging, like CTs, use actually significantly higher radiation, about 15 millisieverts. So you can see that with mammograms, we are using a small dose. And finally, I like to always tell people just exactly what Dr. Shalad said earlier. Those benefits really outweigh the risk with 1 in 8 women developing breast cancer in the course of their lifetime, and finding that adding screening mammograms regularly for breast cancer actually have a 47% lower risk of mortality due to the breast cancer within 40 years, within 20 years. So I think you take that all together, it just makes sense to do it.
Is genetic testing getting more prevalent in breast cancer risk?
There is. So we're doing a lot more genetic testing. Now there's two, I guess, groups of women who we talk about genetic testing for. So one group is women who already have a diagnosis of breast cancer. So in those group of women, we specifically want to look at women under the age of 40 who are developing breast cancers, women who have a family history of breast cancer, but also of ovarian cancer, pancreatic cancer, prostate cancer, melanomas. And so all these other types of family histories we want to look at as well. So if there's a colon cancer family history, and they have someone develops breast cancer, then we want to know about that. There's also certain types of breast cancer are much more frequently found to be associated with a gene that's working not quite right. And so when women have, so for example, a triple negative breast cancer, so that's when the hormone receptors are negative and another marker called HER2 is also negative. So a woman who develops one of those types of cancer at any age, we generally recommend that they have genetic testing as well. Or if women are developing multiple breast cancers. And so say if a woman gets a breast cancer first in her 50s, and then 10, 20 years later, she develops another breast cancer. That's not supposed to happen. It's statistically unlikely. And so whenever that happens, that's exactly what we say. This was statistically unlikely to happen. You should not have developed another breast cancer. Let's see if there's a gene that's working not quite right that made this happen to you a second time. And so we use those things to find those women who have a gene that works not quite right. Now, when men develop breast cancer, that's also statistically unlikely. It shouldn't happen. It still does, but whenever a man develops a breast cancer, then we also make sure we test them and see if there's a gene that's working not quite right. Other people that are tested from a genetic standpoint that affect our breast cancer patients are actually men who have prostate cancer that's spread. And so we're finding more families that have a gene that works not quite right because the men or the dad in the family develops prostate cancer that spreads, and they have genetic testing, and they then find that they carry a gene that works not quite right. They can then test their daughters, their sisters, and then we know that we need to watch them closely. And so that's the other group of women that we test is women who have family members with certain types of breast cancer, certain types of other cancers that sort of raise red flags of, hey, maybe we should check again. First choice, if we can, is always testing the person that has actual cancer. And then if there's a lot of people at cancer, again, testing as many of them as possible. Or if we can only test a couple people, we like to pick the younger group because they're the more likely to have a gene that works not quite right.
Okay, so you have this great tool of a genetic test to identify some red flags, as you characterized. Yeah. And what happens then? Do you reinforce education for lifestyle modifications or additional screenings? What does that look like?
So it depends on what gene's working not quite right. So most people think of the BRCA1 and the BRCA2 genes. They're sort of the most popular, most mainstream that people hear about, but there's actually other genes as well. And so we really try to follow national guidelines, NCCN guidelines of what really is the best screening for that gene. Sometimes that's high risk screening, watching women with mammograms and MRIs. Sometimes surgery is recommended, not necessarily for breast because we have good screening for that. But sometimes if it's one of those BRCA1 or BRCA2 genes, then sometimes having the ovaries out is recommended. There's some other genes that we also see where that they have a higher risk of colon cancers, higher risk of gastric cancers. And so then we work with sort of those subspecialists of making sure our patients are screened and watched closely. The big reason we encourage women to have genetic testing is it provides information. And so it lets you know, are you at a higher risk? Are your family members of higher risk of potentially developing a cancer? And how can we watch you closely?
Okay. Well, I think it's fascinating to know that as we learn more and more about the human body, some of these tools that we can use, and I hope that I hope those tools can help save lives and identify things faster. With screenings, we haven't talked about self-exams. Can you talk about breast self-exams and what things you're looking for?
So we encourage women to have a good sense of what's going on with your breasts. So women should know what their breasts look like or what they know. And so all those things, and even our men who develop breast cancers, is just having a sense of what's their normal baseline. And then if things change, if there's discharge, is it bloody? Is it more like milk? And so bloody discharge, we definitely want to know about. If it's something that's more milky, then that's usually less concerning. But then if the skin starts to become thicker, if it becomes red, hot, swollen, feeling lumps, and sometimes the lump's in the breast, sometimes the lump is in the armpit. And so being aware of those areas as well. Sometimes the nipple pulls in, or the sides of the breast sort of pull in or flatten, or the shape and the contour of the breast changes. One of the most common scenarios that we hear is women who are just in the shower and they're bathing themselves, they're cleaning themselves, and that's when they notice that, oh, that feels different. I didn't notice that before. And so just being aware of your body.
And I would probably also add not to delay having something checked out, right?
Absolutely. Thank you. As soon as you feel something, I mean, certainly call your doctor, get in to see someone in primary care, whoever you see who takes care of your mammograms. And if there's a lump and you're feeling something different over the age of 30, then mammograms and ultrasounds, and we want to investigate. If younger, less than 30, and again, Dr. Angari, please step in but usually those women, they start with an ultrasound.
Agreed.
Okay. All right. Well, it is the bottom of the hour, and it's time for the news break. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. We'll be back after the news. Okay, you're listening to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Brad White. This morning, we're talking with Dr. Sabrina Shalad and Dr. David Angari. And before the break, we were talking about breast self-exams. Did we get to cover everything? Or are there any other comments we wanted to add?
No, I think we got everything.
Okay.
Yes.
Okay, very good. Another thing that I've had some patients ask about in the pharmacy, believe it or not, is if you've got dense breast tissue, should you receive additional screenings?
Sure. So I think the first thing to ask about that is, what is dense breast tissue? And so your breast tissue is made up of fibroglandular tissue and fatty tissue. And when we say breast tissue is dense, it means that 50% or more of that breast tissue is fibroglandular tissue. On the mammogram, that shows up as something white, and it can really make it can look like cancers, because cancers show up as white as well on the mammogram. So dense breast tissue has the ability to mask or hide breast cancers, and it also is the tissue that breast cancer grows in. Breast cancer doesn't really grow in the fat, so it hides it, and if you have more of it, more places for it to grow. So it increases your risk. So this question of should you do additional screening as a result is actually kind of a hot button topic right now, because as of September 10th, the FDA started requiring that when we report our mammograms, we have a statement that goes out in the patient's letter that talks about their breast density. And the statement effectively says, talk to your health provider about considering other imaging tests in addition to a mammogram. However, it's left very open-ended, and there isn't a lot of guidance about what to do, leaving a lot of providers guessing and feeling obligated to do something. So I guess the first and foremost thing that I'll say is actually there is no formal recommendation for what additional screening you should do if you have dense breast. The most agreed upon additional screening tool from the general community is that tomosynthesis, also known as 3D mammograms, is what you should be performing. Most institutions are already performing 3D mammograms routinely, and we're doing that here at Aultman. But if you're going to a facility that's not doing 3D mammograms, I would highly recommend that you request it or find a facility that does do it for you. So now, although there's no general consensus on the need for additional screening beyond that, there are supplemental screening options that do exist. So one of those would be MRI. It's a good supplemental screening tool. It can detect more cancers. And we're now offering a newer, quicker MRI protocol that's called the FAST or abbreviated MRI. That's more affordable. So it gives more access for patients to get it, but it does have some strict qualification criteria to be able to get it. Another one would be an automated breast ultrasound. We also call it ABUS. It's another good supplemental screening option, but it's not as widely available. We actually don't perform it at Aultman, but it's something that you could also look into.
All right, so you had me thinking, I'm sorry. I come from the pharmacy world, and I feel like our daily practice in helping patients meet the needs they have is defined and limited by what insurance companies say we can do. And frankly, even what you providers can let people do. How many challenges do the women you see that need these screenings, do they have trouble with insurance coverage, or is mammography affordable if it's not covered? I mean, I understand that might be a question. It might not be your roundhouse, but I'm sure you have some challenges on a daily basis getting someone what they need.
Yeah, I think that's a good question. And I think that's hard for me to answer because I'm usually not on the front end and I'm usually not the one that's getting the pre-authorizations. Maybe Dr. Shalad could talk to it. To you.
Yes, pick me.
Yeah.
So screening mammograms are covered, which is fantastic. So, and for women that don't have insurance, actually one of the things that the hospital does is they have a screening program. And so we have grant money that helps with women to get screening mammograms. So screening mammograms are great and there's no problem with that. And that even if women are underinsured, don't have insurance, the hospital can help with that. It's the other testing modalities that can cause some difficulty, can cause some headache. And yeah, insurance is definitely can be a struggle with that. And so there was legislation passed in the state of Ohio a few years ago saying that additional screening modalities should be covered or need to be covered by your insurance. The unfortunate part of that is that those additional modalities are not covered at 100%. And it all goes towards women's insurance plans, deductibles, and all those things. And some women have fantastic insurance plans and they cover their MRIs. If there's ABUS, the automated ultrasound, they cover all those at 100%. Other women, not so much, unfortunately. And so for some women, they can, if they need a high risk MRI, that can be as much as $4,500. And that's just for the imaging plus the cost of the gadolinium, the contrast, and then the radiologist reading as well. So all those things can add quite a bit of cost to patients, again, just depending on their insurance plans. Again, some are fantastic and other women get stuck with huge bills. And so we actually have a population of women who are high risk, who need to have screening MRIs, and they're not doing it because they can't afford it, which is unfortunate. And what Dr. Angari was mentioning earlier, that FAST MRI protocol, it's not the best for those women because they really need those better imaging modalities, but it is in fact better than nothing. And so it then becomes that tough struggle of where do we balance, where do we juggle for these women who really need more, but they can't afford because it's not covered or it's not covered at 100%. So those are definite issues. And then the other part of that is there are certain things that we need to make sure that we put in our documentation when we order those MRIs to help make sure that they are covered. And things need to be coded correctly. And it's certain codes that insurance companies are looking for that we try to make sure are entered correctly to help make sure that those are covered.
It is a challenge to speak the language at times, isn't it? Insurance company language. So even with the best intentions. All right. Well, thanks for commenting on that. I guess it's a fight we all fight to try to help the patient for what they need. So how about this? Is breast cancer on the rise?
It's the easy short answer, yes. But it's interesting because our detection is so much better. And so we are detecting more breast cancers, But when they actually look at it, there is in fact a slight increase in the incidence of breast cancer, and they're seeing it more in younger women. And that was one of the things. So the U.S. Preventive Task Force, they previously had an older date for starting screening mammograms. We still followed at 40, but they just now lowered that down to 40 as well. So we were happy that they got on board with what the rest of us were doing. But it's so definitely there is an increase. And so we always tell our women, again, starting at the age of 40, screening mammogram every year. Women younger than 40, whether 20s, 30s, if you notice a breast lump, you notice a change in your breast, please tell your physicians, tell your doctors, tell your care team, anyone in primary care who's taking care of you of, hey, I'm noticing something in your breast.
Okay. Can you just talk about, we've talked a little bit about family history and a couple other things, but are there a defined list of risk factors that could put you at risk for developing breast cancer?
So yeah, so it's a big list that we look at. And so we look at things of, one of the first things is early menarche. So that's the age at which women develop their first period. And so under 12 is a risk factor. Not having babies is a risk factor as well. So nulliparity. The other one that goes along with that is having children at a later age in life. And so it's over 30, over 25 increases risk a little bit, but over 30 also increases risk. And it has to do with breast development. It's those changes that happen in a breast when a woman delivers a baby. And that's the other part, is it's the Paris part, the actually delivering the baby, that affects the breast glandular ductal growth, that can impact breast cancer risk. And then ages of menopause, so the total number of years that women's breasts are exposed to their hormones. So we start at whatever age we start getting periods, and then what age we start. And those years of life that the breasts are exposed to estrogens affect the most common kinds of breast cancer, which are hormone positive breast cancers. So I guess some of those, I mentioned weight again, and the reason I go back to weight is, so we all have fat cells. Fat cells make estrogen, and it's an unfortunate or just a fact of life. You know, fat cells make estrogen. The more fat cells you have, the more estrogens are being made, and those estrogens affect the amount of exposure that the breast tissue is getting. I'm trying to think of other big risk factors, but I mean, those are sort of the biggest ones. And then family history does play a role, but again, it's not as critical of a role. It's that smaller percentage of women is because of family history or genetics.
All right, I have to ask, and if this needs to be tabled, we can do it.
Uh-oh.
Well, I'm just curious about if there's any. I mean, I've seen a study or two about oral contraceptive use in women for prolonged periods of time, that it might increase risk up to 20%. I don't know if you agree with that or not. I just am curious on what your thoughts are.
So I guess in the grand scheme of things, and it's tough because yes, there's hormones there, but the hormones that women are getting now in their oral contraceptives, they are at such lower, I guess, quantities than there were, 20, 30, 40 years ago.
Right.
The amount of hormones that they're getting now are really small in comparison. So it's something that we ask, but it's not one of those big red flags. And the other thing that's interesting about oral contraceptives is, even if there's a impact on breast cancer risk, they're actually preventative from an ovarian cancer risk. So the way they function, so there is that balance there. You can argue one side on breast cancer, but then you argue the other side of, well, it lowers risk of ovarian cancer, which doesn't have as good screening as breast. So there's definitely that side of it.
And I'm curious, I know you probably mean it subconsciously, but you didn't mention smoking. Any direct risks there?
So smoking is one of those things that affects everything. So there have been some preliminary things, but not as much. And the other thing that I didn't mention is actually alcohol consumption. So alcohol consumption is actually much more one of the things that we talk about as opposed to smoking. So alcohol consumption, we try to limit where we try to encourage women no more than 3 drinks in a week. Now, I went to a lecture once, and one of the lecturers said, she goes, now you can have all 3 drinks at one time or spread them out over the week. She goes, but 3 drinks a week. The other part of that, though, is the World Health Organization came out with a statement not that long ago saying that there is no amount of alcohol that is safe to consume. And so that's been something interesting, because we've always said, well, a couple drinks a week total is okay. And then the World Health Organization came out and said, no, like none. And so it's interesting in the breast world, because we've always gone with that, 3 drinks a week.
Okay. All right. Well, it is time for our final break. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Brad White. Let's get back to the last segment of our show. All right, we talked about risk factors for breast cancer before the last break. How about what can we do to reduce our risk for breast cancer?
So one of the biggest things that we always encourage women is, and men as well, so eating healthy. So good, healthy fruit and vegetables. We really encourage a Mediterranean diet. So those are those legumes, chickpeas, lentils, all those good foods, salmon. So really that Mediterranean diet, exercising well. And it's cardiovascular exercise. And so really 30 minutes a day is best. And what's interesting about the exercise is the exercise actually takes precedence over weight. And so yes, we always talk about maintaining a healthy weight, but really that exercise part is key. And then, maintaining a healthy weight and staying active. Those are some of the easiest things that we can try to do. And I say easy, a little bit tongue in cheek, like we all struggle with that, finding time to exercise. And so one of the things that I always encourage my patients to do is try to schedule exercise and activity into your schedule every day. So that way, when life happens, then you still have tomorrow. And so that way, if it's scheduled in your life every day, then you'll get there.
Very good. Do men need to be concerned about breast cancer?
So about 1 in 100 breast cancers that are diagnosed are actually in males. So it's a relatively rare disease, but it does exist. The vast majority of breast issues in males are benign things. And we don't really have a good screening option for the general population that really makes sense. So I don't believe it's something that the average asymptomatic male needs to be worried about because of those reasons. But my advice is kind of similar to when Dr. Shalad was talking about doing your self-breast exam. My advice is just being mindful of your body. If there's a change, like a new lump, skin changes, whatever it might be, seek medical attention, have it evaluated.
Okay. All right. I'm going to kind of filter some remaining questions since we're getting close here. And I guess I'm wondering, what are some common surgical options for breast cancer? Does one provide a better long-term outcome than another?
So the 2 main options that we offer women are lumpectomies and mastectomies. So lumpectomy, or some people call it partial mastectomy, is where we remove part of the breast. And then the other option, mastectomy, we remove the entire breast. Long-term outcomes and survival are essentially equal between the two. And so we offer them both as a balanced, safe option. And so a lot of it comes down to patient preference, what they prefer. Some of it does come down to what's going to be safest for the patient. There are times where we tell women that lumpectomy is not a safe option for you. There's too much of the breast involved, and we really should remove the entire breast. And so those are 2 local therapies. Within each, there's different variations that we can do with our plastic surgeons. So for lumpectomies, we have been offering our women what we call oncoplastic reduction lumpectomies more frequently, where they can get a reduction and a lumpectomy at the same time. And then with our mastectomies, there is a wide variety of reconstruction options that our plastic surgeon can provide to patients, being implant-based or sometimes using their own tissue, sometimes just helping them be as flat as possible. And so we have amazing plastic reconstructive surgeons in our community that we work with to help with the long-term aesthetics of how things look, because most of our patients with breast cancer, we really expect to be around for a really long time, and we want them to be happy when comfortable and confident with how their bodies and breasts look. So that is an important part of what we try to do for our patients.
Okay. Excuse me. Do women with breast cancer always need radiation and chemo?
No, so it has a lot to do with the personality, the biology of the cancer. And so I tell women that so we want to treat our breast locally. And so treating the breast locally are things like surgery and radiation. And so sometimes they go hand in hand. So we want to treat the whole breast usually. So there's two ways to treat the whole breast. You either remove the entire thing or you remove part of it and you treat everything that's left with radiation. And so that's how the surgery and radiation go together. Chemotherapy and sometimes the anti-hormone therapy, endocrine therapy is a whole other thing. That's how we're going to treat the body. And so treating the body is different than how we're going to treat the breast. And so that's how chemotherapy comes into play. So there's the full spectrum of how women get treatment. So some women get surgery and no radiation, only chemotherapy. Some women get all three: surgery, chemotherapy, and radiation, and then endocrine therapy as well. And so it really is a very personalized treatment option. I encourage our patients, as much as we love our friends and our support, like don't always talk to your friends, because so much of their cancer journey can be very different than their own cancer journey, because breast cancer is very different. And the type of care that women get should be very tailored and personalized to them and their cancer. So it is a very individual process.
Okay. Are breast skin lesions concerning?
They can be. So most skin lesions are okay, but sometimes a breast skin lesion is a skin lesion of a cancer that's coming through the skin and onto the breast surface. So skin lesions of the breast, if you notice them, definitely tell your primary care team about them, because it's something that needs to be investigated.
Okay. What is the benefit of going to a breast center? And tell us what makes Aultman Breast Care Center so special.
Um, So one of the things that I love about us being a dedicated breast center, so I have Dr. Angari. And so we have Dr. Angari. He's also done extra training in breast, and he has a team of other radiologists that work with him. And so we all work together as a team. So we have medical oncologists who focus on breast. We have a radiation doctor who focuses on breast. And so we have all these people who are subspecialized, but they're also then further subspecialized in breast care. And so it's great because it really is a full team approach of all these different doctors and care coordinators and nurse navigators, and we have just this great team of people who all come together to help take care of our patients. I think that's one of our biggest strengths is we have this full team of all these people ready to help and help take care of our patients.
Dr. Angari, anything to add before we wrap up?
No, I agree with that. It's the collaborative care. Everyone that's working here is just, very highly passionate, highly motivated to take care of our patients. And that's what us all working together does. It delivers high quality care.
One thing we didn't touch on, and I think it'd be important for you to let the listeners know where Aultman Breast Care Center is, and what method do you get to talk to one of your providers or one of your team? Do you need a referral? How does that look, and how does that work?
So my office is in the breast center. And so we're in the breast center, but we are actually separate from the breast center. And so our phone number is different. And so I'm at Aultman Breast Surgery. And so you can call our office. A lot of our patients are referred, but you can also self-refer. And then for our patients who self-refer, we encourage them to bring as many of their records or let us know where we can get their records from. Dr. Angar, I guess he's a little bit trickier to get a hold of because he's in the breast center. So as he said earlier, like usually don't see him, but he's doing all sorts of things behind the scenes. And so we work really closely together. And so a lot of times it's people will come to my team, call my office, and then we help coordinate everything with his team.
Very good. Okay, well, Thank you to our guests, Dr. Shalad and Dr. Angari with the Aultman Breast Care Center. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health System and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you right here next Friday on News Talk 1480 WHBC. Thank you both for taking time out today. It was very informative.
Thank you very much.
Thanks for having us.
Thank you. Have a great day.
You too.